So I want to talk about something a little bit different than what I normally do when it comes to testing for IGeneX. Um, the basic thing is a lot of you already know this, the difference between what IGeneX does with recombinant serologies versus the standard serologies like you get from the big labs. And very basic thing, old-fashioned serologies, that's the IFA, the ELISA, Western blot. The antigens that are in the test that make the test work, they're derived from an organism that's cultured and then lysed. It's a single species, and what that means is that the antigens that are released are very large in number and very diverse. And a lot of these antigens are not specific for Lyme disease or specific for Babesia or Bartonella, whatever one you're doing on the serology. And the problem is that you get a lot of background scatter. And to get rid of that background scatter, you have to turn down the sensitivity to maintain at least some modicum of specificity. And that's the trade-off with these old-fashioned serologies. What IGeneX does is they don't use the lab grown, organism. They curate lab-created collections of specific antigens from multiple species within a group. So, for example, with Lyme disease, it's not Lush, Borrelia burgdorferi, one or two strains. It's all the different important Borrelia. Same thing with tick-borne relapsing fever, Babesia, Bartonella. So that's a big thing right there. And because these are specific antigens that are created specifically for what they want, the result is very clean, precise, and specific tests with no need for any trade-offs. Because of the trade-offs, the ELISA and the Western blot are very insensitive. The ELISA has about a 50% sensitivity in the real world, and the Western blot perhaps a little bit better, but not always. And, they're false positives, especially with IgM in late disease. The dogma has always been, if you have someone who's been sick for a while and have, let's say, negative IgG, but a positive IgM, they're thinking, well, you're supposed to have IgM only early and not late, and therefore it's got to be a false positive. Well, we who know about Lyme and tick-borne disease know that you can always get a positive IgM late into the illness. But the problem is, and the truth is, if you're doing one of these old-fashioned serologies, the false positive rate is as high as 50% for a late IgM. So that's where that whole controversy came from. However, with the immunoblot, not only are they very sensitive and validated at least 90% compared to the controls, but their specificity, including IgM in a late case, is more than 99%. So basically, in that case, you never ignore a late positive. All right, let me next slide. Now, this is just a graphic illustration. On the left is a Western blot where they lyse an organism, and this band here is the result. This is the control strip. All these different antigens are released. A lot of these are non-specific at all. The ones that are specific, these are patient samples. They're very kind of hard to line up with this control. On the other hand, if you look at the immunoblot, this is a Lyme immunoblot, you see these bands are very, very clear and clean. And the reason why is that they're sprayed on in like a printing process, like an inkjet printer. So instead of being put on a strip of paper like a Western blot and then subject the serum to electrophoresis, electrical charge, none of that nonsense. They just spray on the specific amount and where they want it, and they know exactly what they've got. And in addition to that, again, a Western blot, immunoblot, Western blot in this case is one species. Immunoblot for Lyme in this case here is multiple species, and same is true for the other tick-borne diseases. Now, I just want to give you a little heads up about semantics. I was looking on the LabCorp website, and the Lyme Western blot is called an immunoblot. I said, what is that? They don't have immunoblots. Well, an immunoblot is a non-specific laboratory technique, a laboratory term, that means that you're separating out the different antigens in a way that you can see them all, for example, like on a Western blot. So technically, a Western blot is a form of an immunoblot, but the immunoblot from IGeneX is completely different. It's made differently, as I explained. And not only are they better in our clinical world, but the truth is that IGeneX Lyme immunoblot is patented. They wouldn't patent a test if it was the same as a Western blot. They can't. And it's also FDA cleared, and there's a patent number right down there. Now, this is a bit more information about the IgM paradox, like I call it. This little graph shows you. The blue is the T cell response, which is the earliest response. But then the purplish here, that's the IgM response. It usually begins a week or so into the illness, peaks around 3 to 4 weeks, and it's supposed to go away. But as this graphic shows you, in Lyme, it can persist throughout the infection. The next graphic here is IgG, which is supposed to form right after IgM. But in some of our patients, as you all very well know, this does not happen. So if you look at the statistics, as I mentioned, a 99+% specificity, it's almost never a false positive. So this is one of the very powerful things that show you the value of the immunoblot technology over standard Western blot or ELISA. Now, this is something that's fun. What are all the different bands people talk about? Well, if you look here, these are what the more or less specific bands, what we call specific bands on a Western blot or an immunoblot for Lyme disease. I'm using Burrascano as an example. And 23, 25, 34, and 39, we all think of as the very most specific bands. This column, interestingly, these are the bands that the CDC had recommended for the Western blot. And these are the 10 bands. And look at only 2 of them, actually 3 if you're talking about the one on the bottom, only 3 of the 10 bands are specific for Lyme, and the rest are non-specific. Immunoblot has 37 antigens, which comes down to 31 band groups. And for some of them, like 31 and 25, they have 9 specific different antigens to cover all the different species. For 39, 41, they have 2. So there's no real comparison of how these things are set up and how they work. Now, just when you talk about specificity, I'm just going to go through this quickly. These are references of what the different bands do and what they cross-react with. And just band 41 alone, which is this whole page, look at what they cross-react with: treponeme, leptospira, campylobacter, salmonella, pseudomonas, down, including peripheral nerve axons, EBV, and CMV when it comes to IgM. So that's why if you see a single band on the Western blot of 41 or a borderline ELISA, which might be a single band like that, but that's why there's some non-specific and you can't really believe it. Maybe it is, maybe it's not Lyme, but it could be any of these other ones. So that's a problem. Now, what about these other bands? Now, we thought 39 was really, really specific, but it's also found in treponemes, Helicobacter, Ricketts, and Ehrlichia. The immunoblot technology, their 39 is specific for Lyme Borrelia, but the Western blot and the other forms of standard serologies, it's not specific. So these can cross-react. Band 23, same story. Viruses and even human host tissues can give you band 43 on a Western blot. Leukocytes, band 31. Now, I'm wondering about the vaccine, which is band 31 or antigen 31. If you get an immune response to band 31, are you going to have problems with your white cells? No one has addressed that. Other non-specific ones, 60 and 70 host tissue, number 60 is bacteria as well. And not to beat a dead horse, but look at these are the other non-specific bands: Epstein-Barr, CMV, multiple bacteria for bands, the mid-grain bands, the upper level bands, multiple organisms. And when you have a lysate, when you organize the test based on a organism that's broken up and lysed, that can cross-react with myelin, which is a nerve coating, gangliosides, parvovirus, and rheumatoid factor. So just to tell you, when you're not using recombinant antigens, you really don't know what you're getting. These are the references. All right, now what about seronegativity? When we do the validation for a Lyme immunoblot, again, I'll use Lyme as an example, they found the specificity is very high, 98, 99, 100%, but the sensitivity is also very high. In CDC samples, early disease picked up as many as 93% of cases, and in established disease, it picked up 100%. But we know in the real world that no test is 100% sensitive. So what's the difference? So why is that? Well, in people, antibodies can become sequestered and then hidden within immune complexes. You see, when we have an infection, the pathogen, that's the antigen. B cells make antibodies specific to that pathogen, and they bind together. And when they bind together, that begins the immune cascade. But the problem is antibody tests, including immunoblots, they only can measure antibodies that are freely circulating, not those that are stuck in immune complexes. So if you have someone who has a lot more pathogen than they have antibody, then that's going to, like a magnet, suck up and attach to the antibodies. You can get a false negative. So when is there antigen excess? Well, there are a number of different reasons. They can be from a weakened immune system. Can be from an acute infection when you have more bacteria, more pathogens before the immune system has had a chance to wake up. It's very high pathogen load. And I've had, for example, in my career patients who had multiple tick bites. One person I remember was outside for a number of hours and came in with literally dozens of ticks on him. We had to pick them out with tweezers in the office. Another patient of mine works with horses and would ride back in the brush by the beach, and every single day would have 1 or 2 or 3 or 4 tick bites. By the end of the week, you're talking about dozens that this person has had, and then you get a very high pathogen load, and as sick as they were and as obviously infected as they were, you can get a false negative. People who are immunoglobulin deficient, they may not have enough immunoglobulin to be detected, especially in someone who's very sick. And there are a number of references on this. And this has been studied extensively back in the late 80s and early 90s. So what do we do about this? A lot of people have found that if you give some patients who are seronegative a treatment and then test them again, lo and behold, they become positive. So I know this is anecdotal, and we've talked about this a lot. In fact, I've actually presented this at a conference in the late 1980s. Well, what happens here? Does it work? The answer is actually it does. Why? Treatment reduces the antigen amount, so that means you're freeing up the antibodies. That's number one. Number two, treatments, including functional methods, may improve antibody levels by helping to heal the immune system. So therefore, pre-treating before doing a serology may make the test more sensitive. Now, what's unclear is how much treatment is needed. When I tabulated my first go around was 633 patients, and I found this phenomenon a lot. And I found that 37% of the time they would seroconvert with some treatment, but I didn't tabulate how much treatment they needed. Now, this was again back in the late 1980s, and we had very poor testing. We had very poor testing back then. We didn't have Western blots, or at least not commercially. And so I think the numbers nowadays are even higher. So again, this is something that has been talked about as an anecdote, but then again, we do have not only my experience, but then here's one of the references that I dug up about that. So what recombinant and serologies does IGeneX offer? Well, 2 basic types, the immunoblots and the broad coverage assay. Immunoblot, you can get IgM and IgG. If you get the immunoblot, they can name the species that they find. If they can't name the species, they say not speciated. It means usually more than one species. You might be co-infected with more than one Lyme Borrelia. The Lyme immunoblots are FDA cleared, recognized by the CDC, and patented. They have the highest validated sensitivity of any serology in tick-borne disease, and specificity, including IgM, is typically greater than 98%. A positive IgM should not be ignored even in late disease, and it's available for all the major tick-borne diseases. They asked me to relate to you that they have a special going on. They have what's called now a 4IB panel. It's now in the test form that the 4 different immunoblots are all available together as a discount. There's also a 4IB Plus, which includes a fish test. So I guess I can talk to you more about that through the sales department. So what is the broad coverage assay? Well, while the immunoblood is a clear replacement for the Western blot, the broad coverage is kind of a replacement for an ELISA. Why is that? Well, even though it's a simplified test, it's still recombinant technology. It's kind of a stripped down immunoblot. What do I mean by that? Well, it doesn't say what bands you got. It doesn't say what species you have. And it does combine IgM to IgG. So basically you get a result that's yes or no, a positive or negative. So it doesn't give you that much information, but it is just as accurate as the immunoblot. And it's useful when there's a cost issue coming up. And again, they've also announced a panel where they include the broad coverage assay for the major tick-borne diseases. And it's on the test requisition form. So that's an economical way to get the immunoblot technology. Let's talk about the T-cell testing. What is a T-cell? Well, the B cells make the antibodies. The T-cells participate too, but they don't make antibodies. They themselves are the Pac-Man in some cases where they actually start the immune system going and get the pathogens. So when T cells are exposed to an antigen, they release the cytokines. So in this assay, the patient's T cells are kept alive, brought into the lab, they're grown in the lab, and then different antigens are given to the assay. And if the T cells had previous exposure in the patient, they're going to activate and cytokines will be released, and they measure in the lab the cytokine level. And they measure actually interleukin. So there are a couple of things. Number one, the sample has to get in the lab in a quick, a short amount of time, because you have to have viable cells. That's why sending them overseas to some of the labs in Europe make no sense, because by the time they get there, God knows what the quality is. Now, as you can see from the graph, again, the blue is the T cell response. It's very useful very, very early in the infection before the B cells can be signaled to start to work. It's also found that in really late chronic disease, as there's immune system exhaustion, where B cells start losing function, when the person is really, really sick, you can start to find the T cell assay starts to take over and becomes positive again. So you have a very late chronic patient with a paradoxically negative serology. Think about doing the T cell assay, because that is the time when it does become more accurate. Obviously, if there's a dysfunction of the B cells, you have to rely on a T cell assay to get you a better result. Now, how do you maximize the T cell activation assay? In an established infection, you expect reactivity by both cells, by both T cells and B cells. But as you all know, in Lyme, especially if you're co-infected, either of both types may be inhibited or actually killed. There are publications from NIH that Lyme will inhibit B and T cell function and even kill some of them. Now, if someone has a confirmed infection, let's say by a culture or by fish, and you do a serology, like an immunoblot, and it's negative, then maybe there's something wrong with their B cell response. If you do a T cell reactivity assay and it's negative, and you know they have it because they have a positive direct test like a FISH or PCR, then you have to think that maybe the T cells are not acting so well. So this changes this T cell assay, the IGeneX spot is what they call it, from just a diagnostic test for infection, but to becoming a tool to give you further information on the responsiveness of the immune system. So a lot of people are using this for that reason alone, as well as for diagnostic support. We'll talk about the FISH test, fluorescent in situ hybridization assay. Basically, it's a blood smear. And what they do is they use hybridization, where they use a DNA-based hybrid that will go to will be bound to the RNA of the ribosomes of the organism, and then it's tagged with a fluorescent dye. And these pictures you see, this is Bartonella, typical chain of organisms. This is Babesia. These are the signet, the ring forms, and these are the so-called Maltese cross. And these are the characteristic lesions, or characteristic, I should say, slides of what they look like. So besides this being very clear-cut, nice direct test, you see the organism, you know it's there. Because you're looking at the RNA of the organism, RNA has a very short half-life. Once the organism is dead, the RNA disintegrates. It gets eaten up in the body by RNA aces with a half-life measured in hours. So if you did a FISH test and it's positive, it means the person had that infection the day the blood was drawn. So it's not like, well, maybe in the past. It means that day, yep, they had it. The other beautiful thing about this, it can detect organisms even if they're embedded in biofilms. And we've all seen slides on blood smears of people who are infected, and you can actually see biofilm in the bloodstream with organisms embedded within it. And so this technology helps you to make that diagnosis where other ones couldn't be. When IGeneX does the FISH, their assay is at a genus level. So, for example, for Bartonella, it will pick up all the major strains, likewise with Babesia. And in studies that have been published, the specificity of this at the IGeneX lab has been 100%, no cross-reactivity with any other major tick-borne disease pathogens. And I emphasize that because if you look at the slide on the bottom, you see some dots of fluorescence. This is an artifact. Stains on any slide can precipitate and look like this. So to make an accurate report, you have to have three separate things show up. Number one is fluorescence, the greenish color. Number two, morphology. You have to see the bacteria. You have to see the ring forms, the Maltese cross. And the third thing you have to have is association with cells. Babesia, by and large, are within the red cells, but now they're either within or adjacent to the red cells. So this is what you have to see. So if you just see this, that's just a stain dot. You can't call that a positive. Now, what about the other direct tests? A PCR in the bloodstream is really insensitive. In fact, it's been published that for Bartonella, the pickup rate is only 6%. In other words, 94% false negative rate. Turns out that there are a number of inhibitors in the bloodstream that interfere with the DNA PCR assay. For example, host DNA, even heparin can kind of gum up the works. So it's really insensitive, and that's why if you can do PCR, it's mainly for tissues like biopsy samples and so forth. They've also developed now what's called a droplet digital PCR. And I thought when I heard of this, that this was going to be great because what they do is they break up the serum sample into many, many droplets, and they're individually tested looking for the organism. And that's a way to increase sensitivity. And it does increase sensitivity. But what I found out is, I said to Dr. Shah, looks like really neat technology. Why doesn't IGeneX do it? And she said, we actually have a machine that's up in the corner because we don't use it. And she said that the droplets have to be very, very small. And because they're so small, they have to only include very short fragments of DNA. And when you're looking at DNA for a diagnostic test, the shorter the fragment, the less specific it is. Because DNA is an alphabet with 4 letters, and you have to have a long enough alphabet, a long enough sentence to make sense of it and know what the translation is. So if you're a very short fragment, you run the risk of having a loss of specificity, and that's why IGeneX has this machine that they don't even use. They didn't like the results of it. So what they did instead of a droplet digital is they came up with a culture enhanced PCR. And so they take the blood sample, they put it in a special culture medium, and they incubate it for 2 weeks or so. And the positives are then confirmed by a PCR that they have very heavily validated. In the validation, they did over 700 individual sequencing tests at an outside lab to show this. And in every single case, their PCR result was 100% matched by the sequencing. So the specificity is 100%. It's very hard to know about sensitivity because what's the gold standard? We don't really know. But when you do compare it to a standard PCR, it's at least 10 times higher, and I've seen that data myself. The other thing is that the culture enhanced PCR is another genus level test, and it's very useful in very atypical cases. And there are a couple of cases I've talked about before. One is a patient who ended up having Ehrlichia canis. It's a pathogen of dogs, not supposed to infect humans. And in worldwide literature, only 5 cases have ever been reported, and this test picked it up. Another one pretty famous I talk about a lot, a Babesia culture picked up Colpoderella, which is an organism that's a protozoa type thing. It lives in ponds and in the soil. Only 2 cases in the world ever reported of this infecting human, and they had a case. They didn't believe it. They had it sequenced not once but twice, and sure enough, it really was Colpoderella. So this is good for when you have these head scratches. You don't know what's going on. So, I'm just going to do the culture and see what we got. So how do you increase the sensitivity of the culture and the fish? These are direct tests. They're actually looking for the organism itself present in the blood sample. So in general, these tests are most sensitive when the patient enters a symptom flare. Okay, so at the time of an escalating fever, that's when the pathogens are most likely to be circulating. In Lyme disease and Borrelia, obviously during symptom flares, a lot of us have recognized that Borrelia symptoms wax and wane in a 4-week cycle. And as the patient is starting to flare, then you're more likely to get a positive. What I also found in doing serial blood cultures at Alan McDonald back in the 1980s, 100,000 years ago, it seems, when cultures at different times of day, we were most successful when patients were tested early in the afternoon. And Lyme patients said, I sort of get through the day all right, but by mid-afternoon, early afternoon, 2 or 3 o'clock, it's like the gas comes out and I just have to sit down, I have to lie down, and I might feel a bit flushed. Those are the times you might actually find a low-grade fever, and that's the best time to pick up Borrelia in a Lyme patient. Well, now, on the other hand, we found early in the morning is the best time. That's when they happen to have low-grade fevers, not in the afternoon. And Babesia, during the chill phase, is when you really get the highest yield. Now, the other thing you can think about is, since these are so rarely found in the bloodstream or in such small numbers, how do you raise the yield? The other way that you can do it is by getting more than one test. For example, if someone goes into the hospital with sepsis, they don't do one blood culture. They always do sets of 3, sometimes sets of 6. And the same thing can apply here. So if you have someone who's really a tough diagnostic challenge, you may want to consider having the test done not once, but 2 times, maybe even 3 times. Again, following the guidelines of, what time of day to do it, during the symptom flare and so forth. So that's when these are, little tricks to make them more sensitive. Likewise, very early in the infection, a direct test is great before the immunity develops and starts cutting down the numbers of pathogens. And obviously, in someone who's immune compromised, because the immunity is low, pathogens are high. So the pathogen loads are higher in people who are more sick, and that's a good time to do these direct tests. So the recommendation, actually on time, always begin to culture assay, your random recombinant assay to just see where the patient stands. And as I showed you with the data, consider pre-treating the patient, especially if they're a tough diagnostic challenge. Second thing, I didn't talk much about it today, but I have in the past. For Lyme, when you're testing a Lyme patient, also always test for tick-borne relapsing fever, because there have been studies at IGeneX and even published studies that show that even clinics with physicians and other practitioners will make a clinical diagnosis of Lyme some anywhere from 40 to 50%, even higher of the time it isn't Lyme Borrelia, it's relapsing fever Borrelia. They present exactly the same in those cases, so you can't tell clinically. But if you do a Lyme test and it's relapsing fever, you're going to get a false negative. So you do want to get relapsing fever testing when you have a Lyme patient if you're not sure what's going on. For Babesia Barnell, because it's so hard to diagnose from a laboratory point of view, it's routine to add a FISH test and also consider adding the culture, the CEPCR. Adding the T-cell activation assay, the IGeneX spot, not only can increase the yield of your diagnostic support, it can also provide valuable information about the status of the immune response, as I described. And the culture, it's really good for these difficult head scratcher cases where you say, I don't know what's going on. Let's just do everything we can to figure it out. And before we close, I want to just give a shout out to the IGeneX reps, because they're there to help you. They can help you with how to order the tests, how to interpret the long requisition forms. They can help you with diagnostic codes, if there are any special sales going on. So get to know your IGeneX rep and call on them. They're there to help you.
All right. Thanks, everyone, for joining us. So I am going to start out by talking about why Lyme persists. I figure we need to broach this topic before we actually start talking about treatment. So it's important to understand that it's not just one thing. Persistence is driven by microbial adaptation as well as host vulnerability. So we have to consider the full landscape, from Borrelia's growth state and morphology to its location, whether it's external or inside of the cell. We have to pay attention to biofilm community formation, as well as antigenic variation. And then, what I think is one of the most important points is looking at how it changes the actual terrain of the host. So all of these things matter when we're choosing our treatment, because each treatment doesn't tackle all of these variations. So these are all coordinated mechanisms that promote immune evasion, antimicrobial tolerance, whether it's herbal or pharmaceutical, and chronic persistence. So this is why we need multi-targeted therapeutic strategies when we look at treating Borrelia as well as other vector-borne diseases. So when we are using antibiotics, especially pharmaceutical antibiotics, it's imperative to address all morphological forms. So that's the physiological state of the organism. But then we also have to look at the location of the organism, whether it's outside of the cell or inside of the cell. And then we have to pay attention to break down, dissolve the biofilms. So if we're using pharmaceutical antibiotics to address the spirochetal or motile form, we have to use either an amoxicillin or cephalosporin family. To be able to effectively treat the round body or persister forms, we need to use something like tinidazole or Flagyl. And to address the intracellular forms, we have to use a tetracycline family or macrolide. And if we're using a macrolide like azithromycin, typically you would use hydroxychloroquine to alkalinize the intracellular component to make it work better. And then we also have to use a biofilm agent. And to my knowledge, there is no pharmaceutical biofilm agent. So we're going to be stuck using an herb or natural compound to address the biofilm. So we can use several different things. There's modified citrus pectin, a specialized form. There are several proteolytic enzymes like lumbrokinase, nattokinase, and then there are a bunch of different herbals that we'll talk about as we go through. But the point is that we're going to have to combine 4 different agents here together to make sure that we are simultaneously addressing all of these concurrent forms of Borrelia. Now, if we're talking about using combination pharmaceutical antibiotics and we're using them for excessive durations of time, they can cause further immune dysfunction or damage to the host terrain by disrupting the microbiome, increasing gut permeability, increasing the overall toxic burden, impairing organs of both elimination and detoxification. They can alter digestion and nutrient absorption and intake, and they do typically trigger the formation of persister cells. So, again, ultimately, all of this leading to further immunoincompetence. And so I do think it's really important to note that there's no combination or amount of antibiotics, either herbal or pharmaceutical, that are going to completely eradicate any infection to zero. Antibiotics and herbal antimicrobials shrink the load or the amount of the infection, but in the end, it is the body's immune system that has to come in and completely eradicate it or stop it from growing back. So I believe that immunocompetency is the missing link in chronic infection recovery, no matter what chronic infection we're talking about. So we have the vector-borne diseases like Borrelia, Bartonella, Babesia, Ehrlichia, Anaplasma, Rickettsia, Mycoplasma, as well as other reactivated viruses, whether it's Epstein-Barr virus or the herpes families viruses. And these all persist because of the host terrain remaining in defense mode mostly. We then have ongoing exposures to mold, mycotoxins, spike protein, EMFs, metabolic toxicity, toxins from our environment, as well as trauma that further suppress our regulatory pathways. And this perpetuates the loop of inflammation, further making the host more vulnerable as well as hospitable to the infections. So various antimicrobials, again, whether they're pharmaceutical or herbal, as well as detox protocols, can help to reduce the microbial load, but they don't restore regulation to the immune system. And without immune recalibration, the system remains reactive, inefficient, and unable to fully resolve the infections. So we're going to talk a lot about herbal antimicrobials, but still the question is not how to kill every single microbe. The question is really how to restore a terrain in which the chronic infection cannot persist. So we want to make the body inhospitable and we want to restore immune competency. So a lot of people ask me, what is immunocompetency? And it's kind of a summary of multiple things. I would say number one is effective pathogen recognition. Number two is an appropriate adaptive activation. So having balanced Th1, Th2, Th17, and T regulatory cells, having targeted pathogen clearance that is successful without causing excessive tissue damage in the crossfire, having controlled inflammatory signaling that is appropriate response at the appropriate times, and then finally having a resolution and return to homeostasis. So in a nutshell, it's the ability to mount an effective regulated response that clears the pathogens but resolves the infection without chronic inflammation or immune deviation. And it's so important to understand that immunocompetency is inseparable from gut integrity and microbiome balance. So I'm sure everybody listening to this knows that 70% of our immune cells are in the gut-associated lymphoid tissue, or the GALT. We know that the microbiome regulates T cell differentiation, teaches immune tolerance versus activation. All of this is in the gut, in the GALT. And that intestinal barrier integrity is crucial in preventing chronic immune activation. And when we have disruption of the intestinal barrier, it leads to more inflammation, immune dysregulation, and more inflammation. So really, restoring immunocompetency depends on the gut immune access. So if I had to boil it down to 4 pillars, restoring immunocompetence depends on modulating the cytokine cascade, balancing the T helper branches of the immune system, detoxing, which we can't detox if we're not healing the gut and restoring proper microbiome balance. And then we have to provide sufficient micronutrients for all of our biochemical reactions. Going back to basic biology and biochemistry, our body is structurally built, and our hormones, neurotransmitters, immune cells, everything is built from these biochemical enzymatic driven reactions. And all of these enzymes require a certain vitamin, mineral, or nutrient for them to work. So just providing these patients who are super sick and depleted the basic micronutrients that the body needs to function properly goes a very long way in healing the body, allowing them to deal with the infection, and most importantly, restoring immunocompetence. And don't forget, these bugs cannot make their own nutrients. They need to get them from us. So they're stealing our B complex vitamins, our phospholipids, a lot of our amino acids, essential fatty acids, and the body needs those things to function properly. So we're really left with a problem. How do we kill the infection while restoring immunocompetence? And that leaves us with a clinical conundrum. So how do we effectively reduce microbial burden without further disrupting immune function by trashing the microbiome? And the answer, at least for me, is not simply using stronger antimicrobials or more or for a longer duration. It's restoring immune control. And that's where herbal medicine really becomes essential, because it can address the microbial burden while simultaneously restoring immune regulation, reducing inflammation, and repairing the terrain of the body. So again, herbal medicine works because it can address the microbial burden and the host terrain. If you combine the right herbs together, you will have activity across all morphologic forms, intracellular niches, and biofilm communities. Herbs also provide direct antimicrobial effects while modulating immune function and pushing resolution pathways. They reduce the pathologic inflammation and support mitochondrial energy production. And they do all of this while preserving and restoring gut integrity and microbiome balance. So there is a multitude of studies that have been done that show the effectiveness of various herbal combinations against several of the vector-borne diseases. There are also many books written by the late Stephen Harold Buhner that are a wealth of knowledge, protocols, cited sources, studies showing how effective these herbs are. So I want to now look at the antimicrobial herbs that are typically used to treat Borrelia, Babesia, Bartonella specifically, as well as some other vector-borne infections, as well as chronic viruses. What I want you to note while we're going through here is that they're not just antimicrobial. So every single one of these herbs that I'm going to go over has multiple antimicrobial benefits, but in addition, they protect various organs. Most of them are anti-inflammatory, some are antioxidant. So just pay attention to that, because the wonderful thing about these herbs is that they have a lot of side benefits that are actually targeting our other pillars of our treatment protocols. So we'll start out with Japanese knotweed. So Japanese knotweed has been shown to have inhibitory effects against both Babesia duncani as well as Bartonella hansela. It also had strong activity against both growing and stationary phases of Borrelia. It's also anti-MRSA, and it's effective against both gram-positive and gram-negative bacteria. In addition, it's cardioprotective, it's neuroprotective, it's an immunomodulant, it's an antioxidant, and very strongly anti-inflammatory, and it also protects the endothelial cells. Then we have cat's claw. So cat's claw was shown to be effective against all morphological forms of Borrelia burgdorferi, the spirochetes, stationary forms, round bodies, and biofilm-like colonies. But in addition, it is also cardioprotective. It's an immunostimulant, it's anti-inflammatory, and it's antioxidant. We have Chinese skullcap that has shown to have effectiveness against the log phase spirochetes, latent round bodies, as well as biofilm formations of multiple species of Borrelia. And it also inhibited the formation of bacterial biofilms. In addition, it's protective of the liver, it's anti-inflammatory, and it's also neuroprotective. And it enhances the effectiveness of other herbs and nutraceuticals, as well as antibiotics like doxycycline. Then we have Sweet Annie, which is antibabesial and antiplasmodial. It was shown to inhibit multiple species of Babesia. It also showed to be effective against malaria. It showed inhibition of a number of both gram-positive and gram-negative bacteria. It's directly effective against the stationary phase of Borrelia and was shown to be more effective than the control antibiotics cefuroxime and doxycycline. In addition, it's anti-inflammatory and antioxidant. We then have Cryptolepis, which is antibacterial and antispirochetal. It showed activity against both gram-positive and gram-negative bacteria, and it was shown to be directly effective against the stationary phase of Borrelia burgdorferi, and also more effective than the control antibiotics cefuroxime and doxycycline. In addition, it's antimalarial and antibabesial. It's also anti-inflammatory. Then we have black walnut, which showed in vitro that it had bacteriostatic activity against the log phase spirochetes of both Borrelia burgdorferi as well as Guarini, and had bactericidal activity against other species of Borrelia in the round body form. It also showed activity against staph, Klebsiella, Pseudomonas, E. coli, and Bacillus, as well as Proteus. And it also is anti-inflammatory. Oh, and also it was effective against the stationary and active log phase forms of Bartonella hansela. Then we have cordyceps. Cordyceps is strongly anti-inflammatory. It also protects pretty much every different organ in the body. And it has some antimicrobial and antibacterial properties. There's just too much here to read to you during this presentation, but cordyceps is awesome. If you have mold-related illness, not suggested to be used during your treatment phases. All right, oil of oregano has strong antimicrobial activity against Borrelia burgdorferi, and this was in the stationary phase. It also was showed to be one of the most effective essential oils for eradicating persister cells. It's effective against the biofilm, so it was shown that it could actively dissolve biofilm structures that Borrelia burgdorferi uses. And it also had activity against Bartonella hansela. Then grapefruit seed extract was shown to have activity against both the stationary and active forms of Borrelia burgdorferi. It also showed potential efficacy against different morphological forms of Borrelia, including the active spirochetes and round body forms in a different study. And it's also very synergistic with other treatments. It is antifungal as well. So that can be really helpful, especially if you're using conventional antibiotics. So let's talk about how to build a personalized herbal protocol. So these are the 7 bases that I look at when I am putting together a personalized individual herbal protocol for someone. So first, we need to know, obviously, what organism or organisms we're dealing with. So picking herbs is not just about their antimicrobial activity. So if we can think through the specific immune dysfunction caused by that particular organism, as well as take into consideration any underlying immune dysfunction that that patient already has, we can then pick the herb that is going to help to offset that immune dysfunction. So for example, if you have Th1 dominance, we would use an herb like ashwagandha to balance out Th1, Th2. Then if we know the nature of the cytokine cascade for the particular organism, we can choose the particular herbs that are going to modulate those specific cytokines. Then, if we know which organs and tissues the infection prefers to live in, we can pick herbs that are protective of those organs. If we know what nutrients the organism needs for survival and where it's going to get them from the human body, we can replete those nutrients, but we can also try to stop them from actually being broken down and released from those parts of the body. If we understand the nature of the immune evasion, so is it a vacuole that it hides in? Is it behind biofilms? What is it doing? We can figure out what herb we need to use, for example, to break down biofilms. And then no matter what we're dealing with, we want to make sure that our routes of elimination are open and that detoxification pathways are bolstered, supported, and coordinated. And then finally, and I have this as the last step for a reason, we're going to pick our proven antimicrobial that is going to be effective not only against the specific type of organism. So is it a gram-negative or gram-positive bacteria? Is it a parasite? Is it a virus? Is it a fungus, right? Like, what is it or what are they? So we make sure that we're choosing the appropriate ones. But like when it comes to Lyme, we want to make sure that we're choosing things that are going to cover all morphological forms, as well as their location, as well as biofilm communities. So we're going to go a little bit deeper into a very quick summary of the pathophysiology of Lyme disease so that we can understand and answer these questions. So first of all, Borrelia basically exploits three different enzymes in our body: hyaluronidase, which breaks down hyaluronic acid; aggrecanase, which breaks down aggrecan; and collagenase, which breaks down collagen. So Borrelia uses these three enzymes to basically loosen the extracellular matrix and spread itself through the connective tissue and break down collagen so that it can feed itself, move, spread, reproduce. We can inhibit these three enzymes by combining together Japanese knotweed as well as Chinese skullcap. Then we have the presence of flagellin, which is an inflammatory protein on the flagella or the tail of the organism that basically increases nuclear factor kappa beta, as well as the presence of Borrelia itself increasing the MAPKs. From there, we kick off interleukin 6, interleukin 8, interleukin 1 beta, tumor necrosis factor alpha. And this is that pro-inflammatory cytokine cascade that ultimately sort of like tips and confuses the immune system and keeps us stuck in that perpetuating loop of chronic inflammation and immune dysregulation. We then have an enzyme called IDO, which actually increases something called quin in the body, which is very pro-inflammatory, neuroexcitatory. And in the process of doing this, it actually decreases the production of serotonin and melatonin. And so this is why we can have a lot of like anxious, restless, hyped up patients that are depressed and cannot sleep because of the disruption of that tryptophan pathway that this enzyme IDO sort of shuts off. And so these cytokines continue to be activated during both the acute and chronic stages. And we can actually inhibit all of these pro-inflammatory cytokines using a combination of Japanese knotweed and Chinese skullcap again. And Chinese skullcap is wonderful because it actually inhibits that enzyme IDO. So it stops the overproduction of quin and gives back the body's ability to restore that tryptophan to serotonin to melatonin pathway, which can get our patients sleeping and feeling a whole heck of a lot better. This is a chart that I put together that basically shows all of the herbs that modulate these various cytokines and interleukins and enzymes. So you can have this as your reference. And I just want to stop and point out the power of these three herbs: Japanese knotweed, Chinese skullcap, and ashwagandha. When we combine these three together, we can inhibit the three enzymes that I talked about that break down the extracellular matrix. We can inhibit the pro-inflammatory cytokine cascade, and we can shut down the enzyme IDO. We can balance the T helper branches of the immune system, protect the endothelial cells, and so much more just by using these 3 herbs. And, if you're insistent on using pharmaceutical antibiotics, there is no reason why you can't use these 3 herbs right alongside of them. Now, I'm going to talk quickly about galactin-3. This is an upstream driver of inflammation, and it contributes to chronic symptoms. So acutely, it's protective. It brings in immune cells and coordinates the killing of infection and healing of the body. But when it is chronically turned on, it actually leads to suppression of the immune system. It increases cytokine storms. It causes mast cell activation. It increases the formation of fibrosis. It actually helps to form biofilms and ultimately leads to autoimmunity. We can inhibit galactin-3 using G3M, which is a specialized form of modified citrus pectin. So in addition to modulating galactin-3, it does so much more. It hits every single one of my treatment goals. It reduces 2 of the most potent inflammatory cytokines, IL-6 and IL-beta. It promotes healthy collagen growth, as well as pulls fibrotic tissues from the connective tissue. And remember, with Borrelia, it gets most of its nutrients from collagen and rapidly degrades collagen in the body. It breaks down the biofilms. It binds lead, mercury, arsenic, and cadmium. It enhances natural killer cell activity in a dose-dependent fashion. It supports detoxification by binding the endotoxins, or LPS. And it also helps to decrease galactin-3 in the gut, which helps to restore tight junctions in the gut. And as a bonus, it actually can reduce the severity of Herxheimer reactions, and it also binds mycotoxins. So also, we have these pro-inflammatory cytokines leading to changes of the microbiome, breaking down the tight junctions, increasing gut permeability. Then we have antigenic food particles and the development of food sensitivities. We have the stimulation of the mast cell. We have more toxins entering systemic circulation, again, feeding into increased cytokines, reactive oxygen species, organ damage and dysfunction, and central nervous system inflammation. And this is a vicious cycle that just drives itself. So the take-home point too is, I want to reinforce that the immune system is actually doing what it's supposed to do. It's like the immune system isn't broken. It's responding in an appropriate way. But the changes of the terrain and these sustained elevated cytokines and what is going on actually is what drives the immune response to become maladaptive. And so we have to really focus on healing the body, healing the gut, getting the inflammation under control, and restoring the immune system to get our patients better. So back to how to build a personalized herbal protocol. So again, just a reminder of the 7 things that we're looking for. I've rearranged this into more of a column presentation to think through it. So this is for Borrelia specifically. So number 1, we want to modulate the cytokine cascade. So what are the pro-inflammatory cytokines that are elevated? Interleukin 6, interleukin 8, interleukin 1 beta, TNF alpha, nuclear factor kappa beta, and the MAPKs. Plus, we have galactin-3. So we can use any of these herbs here, whether it's the modified citrus pectin, Japanese knotweed, red sage, cordyceps, and or Chinese skullcap. But when we combine the Japanese knotweed and the Chinese skullcap together, we can actually inhibit all of them because there isn't one herb here that does all of them at once. Then next, we look at the immune dysfunction. So we want to balance Th1, Th2. Typically in an acute Lyme situation, when the immune system is, still doing what it's supposed to do, we will have a Th1 dominance. As time goes on and the infection becomes chronic, often we switch into Th2 dominance because of some of the pro-inflammatory cytokines. In other patients, it can even be a Th17. And we typically have a decrease in natural killer cells. So we can use both modified citrus pectin as well as cat's claw to increase the natural killer cells. And we can use ashwagandha to balance Th1, Th2, Th17. Then, if we're looking at the cells of invasion, as well as what cells are broken down or structures are broken down to release the nutrients that Borrelia needs to feed, we would want to protect the extracellular matrix, collagen, and endothelial cells. But we know Lyme can get into every cell, every organ of the body. So we really want to protect everything, but trying to stick to the basics. So again, we can do that by combining ashwagandha, Japanese knotweed, and Chinese skullcap together. Then we want to look at the type of microorganism that it is. So it is a gram-negative spirochete, right? And then we have to look at the various morphological forms, the fact that it can be intracellular, extracellular. And so I do kind of hit it from as many different angles as possible. And you will see here that the Japanese knotweed and the cat's claw are redundant from the other categories. So really, I'm bringing in 3 separate killers: Cryptolepis, Houtunia, and Sweet Annie. Then to address the biofilm, I love using the modified citrus pectin because we've already used it for so many other reasons, but we can also use proteolytic enzymes, grapefruit seed extract, oil of oregano, olive leaf extract, monolaurin, garlic, curcumin, and another one of my favorites, Chinese skullcap. So I typically am not putting in a bunch of additional biofilm busters because I am almost always using the G3M modified citrus pectin as well as grapefruit seed extract and Chinese skullcap in my protocols. And then finally, we want to make sure that we are taking the micronutrients that the patient is deficient in. We want to be supporting gut health. We can use binders, and I prefer weak binders like G3M modified citrus pectin and or chlorella or aloe, actually, because that really helps to heal the gut as well. And, you know, you can bind the LPS if there's mycotoxins in the mix, et cetera. So there are other herbs that you would want to consider and potentially add in depending on what other symptoms are present, as well as what other infections are there in the body. So this is what a sample herbal protocol could look like. This is written in their Latin names so that you make sure that you're getting the correct species. Yes, they need to be taken 3 times a day. This is the adult dose. You would want to use Clark's rule to be able to find out the pediatric dose. So then going through the herbal treatment of Babesia, I've laid it out in the same way. So goals as far as inflammatory cytokines go are to reduce IL-10, IL-4, and TGF-beta, increase interleukin 12, interleukin 18, interferon gamma, tumor necrosis factor alpha, and nitric oxide. So you can see the herbs there that are typically used. We want to balance Th1 and Th2. Typically, there's a Th2 dominance, but ashwagandha still works. It's an adaptogen. We want to protect the red blood cells, the endothelial cells, the spleen, and the liver specifically. All of the herbs listed under there are effective in doing that, but combining Sweet Annie, Chinese skullcap, Sita acuta, and Japanese knotweed typically is going to give you the most coverage. We then want to use our studied and proven anti-babesial agents like Cryptolepis, Alcornia, Sita acuta, and Sweet Annie. Again, we want to address the biofilms. Now, if there is Babesia in the mix, I typically will include Baluque or lumbrokinase, one of the proteolytic enzymes. If there's Babesia and spike protein in the mix, then I'll go for nattokinase. And then, of course, we want to support detox and elimination always, 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 no matter what infection we're dealing with. So this is what that could look like. And then for Bartonella in my research, as well as, you know, my almost 20 years at this point of doing this, is one of the most stubborn and hard to get to, especially if it is not the only pathogen in the body. So Bartonella by far has the heaviest or most number of herbs and things to consider in the protocol. I have a whole presentation just on Bartonella itself and what it does to the body and how to kind of like impede its progression. So you can, for the sake of time, I'm not going to read through these, but you can look through the thought process laid out as to why you would consider using these certain herbs. And this is what it would look like. As the SIG that I would give the patient. And then I wanted to get through to this because this is actually put together because I don't want you to think, oh my gosh, my patient has the 3 Bs. I have to take all of these 3 protocols together. And the answer is no. As long as we're covering the treatment bases, we don't need to be redundant with a whole bunch of different herbs. So to treat all 3 Bs, we could put together modified citrus pectin, to modulate galactin-3, bind LPS, ashwagandha to balance Th1 and Th2, red sage to give the body back its ability to destroy organisms from the red blood cell and endothelial cells via nitric oxide. We can inhibit the inflammatory cytokine cascade using Japanese knotweed and Chinese skullcap. We can add in red sage if necessary, but you might already be using that to increase nitric oxide production. We want to protect endothelial cells using Japanese knotweed. We want to protect the spleen, liver, central nervous system, lymphatic system, red blood cells, heart. We can do that by combining Sita acuta, hawthorn, red root, and Chinese skullcap along with milk thistle. We can increase the natural killer cells using cat's claw. And then we want to pick our proven antimicrobials. So just combining sweet Annie, Alcornia, Houtunia, and Teasel together with the antimicrobials that we've already listed above goes a long way. And additionally using Cryptolepis. But if all of these organisms are there, I'm going to use a higher dose. I'm actually going to use a half a teaspoon 3 times a day as opposed to just a fourth, which is the dosing in the individual infectious protocols. Then, of course, we want to use pre and probiotics. We want to use nutraceuticals to support detox, replete nutritional deficiencies, counteract inflammation, etc. So, going back to the host terrain, again, these infections remain and become chronic due to this pro-inflammatory cascade driving immune dysregulation. And it makes the body hospitable to the infection. And it causes a lot of these terrain changes and symptoms that we're seeing. Everything from hormone and neurotransmitter disruption to MCAS, to increased intestinal permeability, food sensitivities, digestive dysfunction, nutrient deficiencies, et cetera, the growth of opportunistic infections. And so, it's just important to realize these aren't isolated things in a vacuum. These are all coming from the infections changing the body through these inflammatory cytokines and immune dysregulation. So I used to think that these chronic infections were really the root cause of my patients' illnesses. But over time, I realized that they're really just the tip of the iceberg. And it's so important to identify them and know that they're there because we do have to get them out of the body. But what we have to realize is that they take hold and they're able to live in the bodies and become chronic because of the convergence with a lot of the toxicity in our lifestyle. And a big piece of that is the toxins and the inflammatory foods that we're eating, stressors, traumas, biotoxins, etc. And it's the convergence with all of those poor lifestyle factors along with the infections that cause significant neuroinflammation, gut dysfunction, and immune dysregulation. So if we only focus on killing these infections and we ignore the rest of the terrain of the body, our patients aren't going to get better. And in my experience, this is why many really good treatments fail. So I put together a 10-based approach that is meant to address the terrain in addition to killing these bugs. And so, this is a lecture all in itself. You can find sort of like the breakdown of each one of these, but it's doing a full workup, and it starts with a full history of the patient sitting in front of you and looking at all of the systems of the body, looking for gut function, looking for micronutrient deficiencies, looking for, the presence of mold and mycotoxins, as well as spike protein, other opportunistic infections, etc. And then using Band-Aids if necessary while we're working on these root causes. But we have to block inflammation. So blocking galactin-3, blocking the inflammatory cytokines, blocking inflammation from our diet, right, is huge, and from our environment and our lifestyle. We have to restore proper autonomic nervous system function and resolve dysautonomia. We have to balance the immune system. We have to get the body to exit out of the cell danger response and resolve the immune response. We have to build the gut. We have to bolster detoxification. We have to bind toxins. And finally, blast the bugs. And I put blast the bugs before breakdown biofilms because, killing the things that are sort of out there and accessible first, kind of like draining the bucket before you let everything go that's behind the biofilm, a lot of times will help patients to tolerate the treatment better and not have such severe herxing. So I want to leave you with this. Chronic infections do persist mostly because of immune dysregulation, not because of microbial persistence alone. It's the inflammation, the gut dysfunction, cellular danger signaling that all create a terrain that permits and supports the ongoing infection. So antimicrobials, whether they're pharmaceutical or herbal, they reduce the burden, but they're not going to restore resolution. And we have to restore resolution so that we can get off antimicrobials in the end without the infections growing back. So true recovery requires addressing the interconnected drivers simultaneously: the immune dysregulation, the inflammation, the gut microbiome integrity, detoxification, and restoring the ability for effective cellular energy production. So thank you. And I will also leave you with an invitation to come and hear Dr. Burrascano, as well as myself and 14 other amazing speakers, speak at the annual Lyme Bite Symposium. It is at our new home, which is the Marriott Pompano Beach Resort in Fort Lauderdale. And it is always the second weekend in November. So this year, that's the 13th and 14th. And on Friday night, we're having a beachfront gala to benefit the Limelight Foundation, who provides grants for children as well as young adults under 25. And they actually provide an amazing grant. It's about $10,000 per recipient, which is huge. So please consider joining us.
Excellent. Thank you, Dr. Hinchey. That was a fantastic presentation. It's
Thank
really
you.
great to hear about treatments. I mean, I know working at IGeneX, we're kind of in our lane of testing, but there's this whole other side of, how does the patient get better? And that's what it's all about. So,
Right.
excellent. And thanks everyone for sticking around. If we can maybe take questions for the next 7 or 8 minutes. I know we have quite a few questions already. You can enter your question at the bottom of the screen. You should see a Q&A prompt, and we'll try to get through some of these. I know it's getting late on the East Coast, but there were a couple of questions related to treating tick-borne diseases and mold at the same time. So Dr. B or Dr. Hinchey, you have any comments on that?
Do you want to go
Sure.
first or do you want
No,
me
you
to?
go ahead. Sure. You go ahead.
So what I would say is the rule of thumb is that if you have a concurrent mold and vector-borne disease infection and you're going to go the pharmaceutical route, you would want to treat the mold first, because when you take the antibiotics, you will increase the growth of fungal bodies in the patient's body. Now, if you're doing it from a naturopathic perspective, it's funny you should ask the question, because Dr. Jill Krista and Jill Krista is my mold guru, we are actually doing kind of a joint talk on how to treat a simultaneous mold and Borrelia infection together. And it can be done. And because the herbs that we're using to treat Borrelia do not encourage fungal overgrowth, you don't have that same phenomenon that you do when you are using pharmaceuticals. It's literally like a whole 2-hour discussion I could have. So I'll leave it at that for the sake of time.
Excellent. I believe you mentioned pre-treatment, Dr. B, in your presentation. There's a question here. Could you say more about what pre-treatments would look like as recommended?
Okay. Can you hear me well this time? I tried to change my microphone. Is that better?
So much
Sounds
better.
great.
I turned off all the filters and the background and blah, blah, blah. It's just straight microphone. Anyway, sorry about that. So, like I said in the presentation, we don't really know how much you need to give someone. My impression clinically from doing it so many times is you have to do enough to get the patient over the Herxheimer hump. Because Herxheimer, by definition, is the lysing or the killing, the breaking up of the organism. And you want to decrease the germ load so that you free up the antibody. So, for example, with Lyme disease, the Herxheimer occurs during the first several days. So by the end of the first week and into the second week might be the time to do it. Babesia is a little bit longer in terms of the time you need to kill it. Bartonella is actually shorter. But the basic idea is you want to be giving a treatment regimen that will get the person a little bit better than their baseline. And it doesn't have to be a lot better, but just past the Herxheimer, a little bit better than baseline. And I think that's all you need to do. Now, in terms of what protocol, again, it depends on whether you're doing antibiotics or botanicals or the combination of the two. But it has to be strong enough to do enough killing that you're going to decrease the germ load and increase the free antibody.
Excellent. Here's one question specific to Dr. Hinchey. Dr. Hinchey, you often say that Lyme and co-infections is a clinical diagnosis. What if the patient can't afford specialty testing like IGeneX? How do you then treat them if chronic Lyme is suspected?
So, yes, I do say it's a clinical diagnosis. And I think anyone, who deals with Lyme would agree with that. We use tests to support as part of that clinical diagnosis. So, I mean, looking at all of the symptoms, looking at what other disease processes in the body, infections, et cetera, have been ruled out. Like, we don't want to just say, oh, that looks at Lyme, so we're going to randomly treat it. We want to do the best that we can to make sure that there isn't something else going on that could explain it as part of the clinical diagnosis. I'll try to keep my answer short because there's so many more things that I would say. But I also think there's a difference, right? So being a naturopathic doctor who specializes in using herbs and lifestyle interactions, when you are balancing like the benefit versus the risk, it is a very, very different benefit risk ratio than it is if we're talking about going on combination pharmaceutical antibiotics or antiparasitics, right? So, and I'm not dissing antibiotics like pharmaceutical antibiotics at all, but I believe that no matter what intervention we're looking at, we should look at the benefit versus the risk. So I do have patients who will come to me and they will say, look, I can't afford testing. And you might hear the scenario where they've never been right since. And, they had the tick bite previous, but they weren't, they were improperly worked up and diagnosed and whatever. And so then, I think doing an empirical treatment, because you're not really posing any harm, and seeing how the body responds, that I will do and do with patients. And I know that I have colleagues who are using pharmaceutical antibiotics that will do empirical treatment as well. And if you're responding to the treatment that you're being given, then that is evidence, right, that you are on track with the right clinical diagnosis. I don't know if Dr.
Excellent.
Burrascano, you have anything to add to that.
Well, as a medical doctor, the first thing you want to do is make sure you have the right diagnosis by ruling out other things that might be important. Obviously, cancers, hormonal imbalances, and so forth. But assuming that has been done to a reasonable degree, some of the things you do first, actually, you spoke about, you fix the terrain. And so at my first patient visit, I spend the time working on getting their terrain better, and run the tests if they can afford them. And then they come back to second visit with some benefit to the terrain and some test results to go through. So that always starts the treatment protocol in my mind. And then you decide if you're going to give empirical treatment or not. And if you do, you look for what? A daily diary, temperature record, symptoms getting worse, then getting better with the Herxheimer in a pattern you expect. And then you just have to follow them very closely. And that's the bottom line.
Excellent. We'll take a few more. There's a couple questions just about ordering IGeneX testing in general, and do you need a doctor's prescription? Yes, for IGeneX, you do need authorization from a provider. We do also have AccuDart Health, where in that case it's direct to consumer. You don't need a provider. Let's see, a couple more questions on treatments. Do you ever use peptides to help modulate the immune system? Please explain if not, or if yes, and what your favorites are.
That right there is a lecture into itself. The
Mhm.
short answer is yep. I use peptides for mainly the healing. Dr. H also talked about how, especially Borrelia likes to feed upon our connective tissues. And once you start the treatment protocol going, adding the different peptides really can help with stabilizing that and helping it to heal.
Excellent. Do you use andrographis for any form of Lyme? I'm not familiar with that, but
So yes, I like andrographis actually to be used topically with an acute tick bite, and then also by mouth with an acute tick bite. Andrographis I've stopped using as part of my main my main herbal protocols that I use, because it can cause a lot of GI upset, and it causes this strange rash that really freaks patients out in upwards of about 50% of patients. It's very strongly anti-spirochetal, but I don't find the need to use it other than in an acute situation. And I'd prefer to not have to be fielding calls with people having rashes and GI upset with everything else that they already are experiencing.
excellent. Maybe we'll take one more. I heard Dr. Hinchey mention briefly that cordyceps is contraindicated when there is mold. Can she elaborate further?
Yeah, so it's a mushroom, so it's a fungus. And so when you are actively when you're in the beginning stages of dealing with mold related illness, it's just recommended that you don't use mushrooms or other fungal family things in the treatment. And Dr. Krista goes through this in her mold certification course. She talks about when you're trying to resensitize the body at the end to be able to tolerate various molds and whatnot, then it's safe to introduce. But you don't want to use it in the beginning, because you're trying to get the immune system to quiet down to all fungal family things. And so putting that in your body every day, 3 times a day, just not a good idea.
Well, you see, the body can be affected by the infection by mold organisms. It can be affected by their secretions, the mycotoxins, and the body also can become allergic to the organisms. So if you have any one of those things going on, you'll be under, mold types of treatments. And if you have a component of allergy or mast cell activation from the mold, and you're going to add another mold product therapeutically, then you might be adding fuel to the fire. So it's not just killing organism. It's not just getting rid of mycotoxins. It's also the allergy component.
Excellent. Okay, so I think we'll leave it there in terms of questions. There's a few more. We will definitely try to follow up after this call before the end of the week directly with any folks who have outstanding questions. But before we sign off, I just want to open it up for Dr. Burrascano or Dr. Hinchey to make any final remarks or comments that you want to share. Anything else on your mind?
Ladies first.
You can talk about
Um,
Lyme bites.
well, I already did that. No, I'm always happy to answer questions. You probably the easiest way for you to reach me would be through Lymecore Botanicals. Reach out to cj@lymecore.com, or you can just go through, our inquiry page. And again, I'm always happy to help or answer questions.
And, I just want to add about another sentence or two about the AccuDart. That's an at-home test you buy online, accudarthealth.com, and they send you a kit. You do a finger stick and get some blood, and you send it off to IGeneX for processing. That does not need a physician prescription. It's great to do when you have telehealth and you can't run to a lab all the time. It's great if you want to get family members tested, and they do test for all the major tick-borne diseases, and they even have package deals, I guess. So I'm not part of the business. I don't know the details of that, other than to say that it's a great way of getting a recombinant-based assay less expensively and much more conveniently than having to go to a lab.
Excellent. Well, thanks again, Dr. Hinchey and Dr. Burrascano. This has been fantastic. And again, the slides and the recording will be on the website, IGeneX.com website tomorrow. So thanks everyone for staying around. And until next time, have a good evening.
Good night, all.
Bye.